Can everybody see my screen? Perfect. Sorry, this is just obviously the obligatory beginning of any Zoom talk. Can you see my screen? Interestingly, my disclosures have not changed. It's disappointing. Here are the objectives here for this talk. I just want to quickly talk about the different MRI sequences for common areas that we can approach with MRI surgery. I want to have you understand the utilities of SPECT CT, and also quickly touch upon ways we're using intraoperative ultrasound for minimizing our surgeries. So again, magnetic resonance imaging, I think everybody's familiar with this. Is just a standard picture and definition. And one thing that is really has been very, very interesting for me the last couple of years is that I think imaging of the neural axis is lagging behind the precision that we're bringing to the table now with full endoscopic spine surgery. And this is in particular true in certain areas such as the cervical foramina, for example. And so here's a retrospective study, and they did a nice, grading. They developed a grading scheme for cervical foraminal stenosis. And the more foraminal decompression surgeries you do, in different ways, and I'll get to that in a moment, the more important is to sort of be able to assess that. I think everybody in their practice, we see patients that have multiple nerve roots compressed. With chronic cervical radiculopathy, the diagnostic in terms of clinics is very difficult. And so it's really helpful to have very precise imaging. And so there's up to 3 grades. And what you're looking at is the nerve root itself, and the fat, again, around the nerve root. And these are oblique images. And so I would encourage anybody who has a patient with cervical radiculopathy to request these sagittal oblique images. As they really reveal not only the presence of stenosis, but they also can tell you what the nature of the stenosis is. As in some patients, we have, more ventral pathology, where, ventral approach is more beneficial, or a posterior approach. And it's not uncommon to also see little synovial cysts in there. I think that's a really nice imaging modality for this. And not only is it nice to see, but it's also, there's another study by Dr. Park, where they looked at 26 patients and showed that oblique and axial images were similar to diagnose foraminal stenosis, but the intra-observer agreement was significantly higher with oblique views. And here's an example of a C6, C7 foraminal stenosis, and it's just very obvious to detect that. So I think this is a very, very helpful technique. Why is it helpful? Well, for cervical foraminal stenosis, we have different options. And starting with the least invasive, that's a posterior endoscopic cervical foraminotomy. And so that's a great procedure for unilateral grade 1 to 2 foraminal stenosis and for foraminal cysts, synovial cysts, again, which are not uncommon if you look for them. Disc arthroplasty is obviously for unilateral or bilateral. I use them for higher grade foraminal stenosis. For grade 3 foraminal stenosis, where you have encroaching of the pedicles, the cervical foraminotomy gets to its limits. And also if you have a ventral cervical spinal stenosis that needs to be addressed, and cervical disc arthroplasty is a fantastic option. Or if there's a grade 3 foraminal stenosis, ventral central stenosis with instability, then as an ACDF, and then with multiforaminal and multisegmental stenosis and instability, then a posterior segmented instrumentation comes into play. But this is very helpful to sort of choose what type of procedure you can do for these patients. Let's switch course a little bit. So let's go to the lumbar spine. In the lumbar spine, one of the most frequently overlooked areas is lumbar lateral recess stenosis. Here's a Rauschenigg slide here. And what you can see there is, sorry, let's go back here. Can you guys still hear me or not? Because so here's a Rauschenigg slide. Great question. My earphones kind of gave out. Can you guys still hear me, or is it or not? Can somebody confirm? Can you guys hear me or not? Okay, it says that I'm still okay there on my side. So please let me know if you don't hear me.
We can hear
So
you well.
here's lateral recess in the lumbar spine, and the lateral recess in the lumbar spine is comprised and confined. Here's a slide. So here's dorsal, here's ventral. Dorsal, it's confined by the yellow ligament covering the facet joints, and ventral is the annulus. And what we can find in there is typically the traversing nerve root. And this is what it looks like on axial images. And I would encourage everybody to really look for the traversing nerve root, in particular at L3-4-4-5. The lateral recess stenosis is very, very common. Try to find the traversing nerve root as outlined here in red, and then try to find the tangential sort of like confinement of that space, both dorsally and ventrally. And we just looked at this in a paper, very few patients, because we wanted to very specifically look at the very certain patient population of patients that had unilateral lateral recess stenosis and not contralateral recess stenosis that was symptomatic. And so we performed a medial facetectomy outlined here, so resection of the infra-articular process, resection of the supra-articular process outlined in blue. Here's the pedicle. And we got a nice rostrocaudal extent and decompression in these patients. And what we found in this patient cohort is that patients on the symptomatic side, the angle was around 20 degrees. And the asymptomatic side, it was 35 degrees, which makes a lot of sense. So once the angle gets very acute, the nerve root cannot slide in and out the lateral recess when we move. And so measuring that angle helps with the decision making. And when it's the decision making needs to be done is, for example, if a 4-5 lateral recess stenosis in the setting also of moderate L5-S1 foraminal stenosis, really nobody can tell you if the L5 nerve root is compromised in the lateral recess or an L5-S1 foramen. So having those measurements can help you guide and get into the right direction. Now, lateral recess stenosis also presents a little bit different clinically. It's typically more an acute pain, typically relieved with leaning forward, while foraminal stenosis and foraminal pain is typically more what we understand on the mechanical back pain and mechanical leg pain. And so then the lateral recess height is measured right at the medial aspect of the traversing nerve root. So measuring that angle and measuring the height of the lateral recess, I find that very helpful when I have to determine if a radiculopathy comes from the lateral recess versus the foramen. And then again, in this small series, 10 patients, roughly 60 years old, we had 8 out of 10 patients had an MCID if we followed these guidelines and if we decompressed them in an interlaminar fashion. Now, the nice thing is now that the lateral recess can also be decompressed via transforaminal route, and that's something that we are studying right now in our research group. And we'll soon hopefully have some results on that. So concluding here right now, lateral recess here quickly before we go to the next point is the interlaminar technique provides really nice, here outlined in red, nice rostrocaudal decompression, and the transforaminal technique I used in particular when patients had previous posterior surgery from traditional surgery. And the nice thing also, transforaminally can also go central. And there's quite a lot of athletes I've been able to treat that, and young patients heal their disc quite nicely. So, and again, one thing that is also very helpful is diagnostic blocks, which we perform often to kind of really narrow down where the pain comes from. A couple of words about SPECT, which is also helpful in working up these patients, either pre-op or post-op, if there's persistent pain. So it's the technetium 99 scan biphosphonate bone scintigraphy. And what it does, it detects alteration in bone metabolism. The nice thing is it's not as prone to artifacts because it's a nucleotide scan, and in particular useful in patients after fusion surgery and with persistent pain. And so here are a couple examples from a recent paper on this topic. So it helps you with detecting screw loosening. So you can see this here. And the CT scan and on the SPECT. It also is helpful to detect subtle or not so subtle pseudoarthrosis. So you can see that here at L5-S1. So for these two, again, screw loosening, you typically see pretty well on the CT scanners here, so probably not necessary. But often these subtle pseudoarthrosis, in particular after multi-level MIST lifts or other fusion surgeries where only the anterior column was fused and you have ever so slightly posterior motion in the joints and a non-union, this can be very, very helpful. Another thing is nice, as we've heard earlier about SI joint fusions, it really lights up at SI joint disease. And here's one of my patients that had a large lateral osteophyte that was lighting up the bone span SPECT, and we just did a standalone extreme lateral interbody fusion, as here with the lateral plate. And so that's an application. So last point here that I want to make quickly, wanted to also present our work on ultrasound imaging. Well, you might say that it's not such a, this is not a directly minimal invasive application here right now, but in a way it is, because it allows us to tailor the decompression surgeries in our acute trauma, in our acute spinal cord injury patients to the decompression that the patient needs. And I want to convince you quickly here that this really has changed our practice entirely at Harborview. So 65-year-old female, she presented to the ER after a low velocity motorcycle accident. As you can see, she had a previous history of an ACDF. You can see the plate here, and there was a large osteophyte that was not addressed by the ACDF. And so she comes in now to our hospital, Asia A, so let me go back here quickly. With a sensory level at, I think it was C4, and you can see the MRI. And again, so what do you do with this patient? In terms of diagnosis, only a quarter of these patients improve, and so impossible to know what the outcome of this patient is going to be. And so what we have been doing more and more is these ultrasound technique where you use a contrast agent. The contrast agents are small micro bubbles that have a core made of heavy gas and a shell that is comprised of lipids or polymers. And what it does is the ultrasound shoots in a signal, and it gets the bubbles into a vibration or resonance, so very much like a music instrument or a bridge that starts swimming. And then the signal that you get back is so strong that you can actually track individual bubbles. And very quickly here right now, this is just from our lab studies, is that if you use this type of imaging in our laboratory at the University of Washington, and we do this in rodents that have experimental spinal cord injury, then we can predict very well what the functional outcome is. And again, in rats, we use a scaling score of the highly locomotive function as a BBB score. And you can see the perfusion deficit here on sagittal images gets larger the more severe the injury gets. And you can see that measuring the perfusion deficit helps us to predict where these animals end up. So that gets us back to this patient, and the explanation why this is really helps us to do these cases in a more minimally invasive fashion. So here's the ultrasound. You can see the sagittal image of the spinal cord. Here's this big osteophyte. You might remember that from before. Now the bubbles are coming in, and you see a perfusion deficits here that sort of remains non-perfused. Looking at the data right now, actually, this patient would have had some recovery ahead. However, because it's still a research project, so the patient had some recovery of a hand, 2 out of 5, a little bit of a hand intrinsics and proximal lower extremities. But given the slow recovery, both the patient and the family decided that incomplete neurological recovery is unacceptable, and care was withdrawn. And I think where we use this technology now is not only to prognosticate this, but also to help us to optimize our decompression. So what we do now with spinal cord injury patients, we do a laminectomy in a more minimally invasive fashion, still using traditional technique, but then tailor the decompression to exactly where you have to be. And so we add more decompression as needed. And so that helps us to minimize the amount of bone work that is needed for that, even though it's still traditional technique, obviously. And here we can see in our patient cohort that this biomarker in patients seems to predict quite nicely if a patient still has improvement or no improvement. So it seems to be very, very helpful in the acute phase to tell us if these patients recover or not. To conclude here, MI, as we showed in different examples, especially in cervical foraminal stenosis and lateral recess stenosis, is very helpful to define if an area is stenotic enough that it warrants a decompression. SPECT imaging allows to detect areas of increased metabolism and are helpful to make decisions on postoperative or de novo patients. And intraoperative ultrasounds provides information of spare tissue following traumatic spinal cord injury, and also information whether a decompression is complete or incomplete. And so I want to thank everyone for listening, and if there's any questions.
Thank you, Christoph. That was a great talk. Any questions? So I had a question, Christoph. So for the SPECT CT, there are a lot of people that don't agree that it's helpful. What has your experience been in terms of false positives and false negatives? And another question is, you discussed this ultrasound technology, which, as you know, I'm very excited about seeing where it goes. And you talked about how it's guided you in terms of bony decompression. Has it helped you with figuring out whether a duroplasty is a good thing to do in some patients versus not? Because I know that's one thing in spinal cord injury that people are, potentially excited about.
Yeah. Hey, thank you so much, Osama, for the question. So regarding the bone SPECT, I think it's really, again, it has a very high sensitivity, but a very low specificity. With other words, there's a lot of things that light up. I think that it's really helpful if, again, in cases, typically after fusion surgeries, in these cases where you have, for example, that the dorsal column didn't fuse and the screw is just ever so slightly loose, and there's just a minimal movement. And this minimal movement really drives our patients bonkers. And so I think that's really helpful to find that. But again, an adjacent level, there's so many other areas that can light up. So it's really helpful. I think you have to have a strong suspicion on MRI or CT scan and then specifically address that issue. I think then it's useful. Regarding your second question, regarding the ultrasound is, one really interesting thing, and probably not entirely the topic of this meeting here right now, but in my laboratory, which deals with spinal cord injury, the whole world relies on these rodent spinal cord injury models. And what we have found the last couple of years more and more is that the subarachnoid area and space is very different between rodents and humans, but also in the human spinal cord in different areas. So with other words, the ratio between spinal cord and subarachnoid space is much smaller in the cervical spine versus the thoracic spine. So in the cervical spine, we do see sometimes that the spinal cord expands enough to touch the dura, albeit it's not as frequent as we initially thought. And so that is an interesting topic that we're trying to figure out as we speak right now. And so the question is, in order to decrease the transmural pressure for the vascularity in the spinal cord, as you know, Brian Kwan is trying to do some lumbar drainage to decrease the CSF pressure. And I think, Osama, you've done some cases like that too. I think you remember that you told me, versus opening the dura. And probably opening the dura does something very similar, is that you have a duroplasty where the pulsations of the CSF and the pressure of the CSF is altered enough that it might make a difference. But I think that's exactly where we are right now, is I think we have to start understanding how, the pressure gradients behave in humans, because I think there is something to be gained there. In rodents, with doing an appropriate decompression, we're talking about 20 to 30% of neuroprotection. And that's huge. If you see that a patient actually with 10% spared spinal cord tissue can have pretty much a normal functional exam. So the reason I put it in there is because I think having that imaging in the OR allows you to minimize what you do in the OR, and then really have a targeted approach towards bony decompression or additional maneuvers that you want to do. So I think intraoperative ultrasound is really an amazing technology that neurosurgery should embrace, because its utility is mainly limited by calculation power. And as we all know, calculation power doubles every couple of years. So I think there's a lot of good technology to come there.
Well, thanks, Christoph.